We'll just get started and do a little bit of housekeeping. So for those of you who don't know me, I'm Debbie Magwood. I'm the founder and the executive director of the West Island Cancer Wellness Center. And welcome to our series called Zoom into Wellness. We offer different speakers and different topics every month. So if you want to keep an eye on them, you just need to go to our website and look under the monthly calendar. The West Island Cancer Wellness Center is a registered charity, so we rely on donations. And the reason I'm talking to you about this is we're entering into our Giving Tuesday campaign. And in that campaign, every single donation made is matched. So $100 is really $200. So if you're interested in donating, it's a fantastic time to do so. La présentation sera en anglais. Vous pouvez poser les questions en français dans le chat. Okay, we'll be asking you to pose questions, not to unmute yourself, but to put it in the chat box. And if there's time at the end, we will ask our presenter those questions for you. Always best when you have a presentation like this to go into presenter mode. So it's either in your left or right-hand corner as a setting. And the best way to know if you're in presenter mode is if you see me and only me as I'm talking to you, then you're in the right mode. If you see all of you in little boxes, you're in the wrong mode. So best to use that mode. And please, please don't take any offense. We will have you muted throughout the presentation. If we see that you become unmuted, we will mute you quickly because we're trying to have no background noise. Also, for your information, we will be taping this session, but none of your faces, even if you're on camera view, will come out in the tape. So you don't have to worry about that. But if you do have any concerns whatsoever, you can go to your settings on the bottom of the page and just click off your camera so that we won't be able to see you. But I personally love seeing your beautiful faces smiling at me. So please do, and I'm sure our presenter would feel the same way. So without further ado, I'd like to introduce you to our esteemed presenter today, Dr. Mary Jane Esplen. She's a full-time professor and vice chair in the Department of Psychiatry in the Faculty of Medicine at the University of Toronto. Dr. Esplin works at the University Health Network as a scientist and is the inaugural director of the De Souza Institute. She has held prior awards for her research in the field of psycho-oncology, and she has a PhD in psychosomatic medicine at the Institute of Medical Science at the University of Toronto. Following her PhD, she completed a postdoctorate fellowship in cancer genetics and psychosocial oncology. She is also a therapist and has received several awards and given numerous workshops and keynote speeches in psycho-oncology. It is with great pleasure that I present to you Dr. Mary Jane Esplen and her presentation on restoring body image after cancer.
Thank you. Thank you very much for the introduction and welcome everybody. It's a pleasure to do this. You can hear okay? Let me know if you can't, right? I'm going to share my screen. Let's hope that goes well. We were trying it. Share, hold on. Okay, there might be a little black box on the right, which we don't seem to know how to get off. But anyway, that's my fault, I think. But what I'm going to do is I actually did some research in this area, and I'm very interested in this area. I also work in the area of body image. And because I can't see everybody, I'm seeing my screen and my slides. Just interrupt me if you need to, or if you can't see something, or if something happens with the technology, just please interact. But it's really a pleasure to be here, and I'm hoping to have some time at the end. I'm going to give an overview, and some of my work's been in breast cancer or colorectal cancer, and I also worked a lot in genetic testing. But a lot of what I'm talking about, I really think applies to all the cancers. And The trial I'll talk a little bit at the end about was done in breast cancer, but I'm really in touch with other people in the field of psycho-oncology to apply similar techniques in all the cancers. So I'm hoping you get some information about what's a normalized reaction, what some of the major aspects of body image are in relation to cancer experience, and also maybe some things that you can do about it. So I'll try to answer the question whether we can fix what I think we've broken. It's our system that basically has done the harm, not just the cancer. So let me see my slides. Okay, so I got interested in this. I've been interested in psychosocial oncology for a long time. I've worked in the field for about 3 decades. And I've always been interested in individuals that have more difficulty with adjustment because I have an interest in psychological intervention and programs. And, just so you know, and to give you some background, almost everybody that goes through cancer will have some distress. And it depends when you measure anxiety or depression along the way, but it's pretty normal to have some psychological symptoms when you're going through cancer, when the cancer treatments end, and really for a lot of the trajectory, because there are different things that kind of emerge along the way. There's a smaller subgroup that have more difficulty. And I was asked, there was a call for research in Canada on psychological interventions in breast cancer. And an oncologist said, Mary Jane, can you do something about body image? There was a call for grants, and I'm always interested in writing grants on especially trials for psychosocial interventions. And I thought, body image in breast cancer, I mean, we knew for a long time there were body image issues. And I took a look at the literature, and this was in the mid-2000s, maybe, I think, when this grant call came. And there was very little actually done yet in the research area in specific psychosocial programs to address body image. There sometimes were group therapy programs that might have one session on body image, but there was very little that was very specific, even in breast cancer, which kind of shocked me. So we wrote a grant and we got it, and it was to develop a group intervention, which I'll talk about at the end. But what I was interested in, I've always been interested in anxiety and depression, and to really help patients with those symptoms, you need to really understand what are their concerns, what are the specific issues that are contributing to those kinds of feelings. And there are lots of different ones in the cancer experience, but one of them is body image. And we actually also have measures for body image adjustment. So one of the things I want to tell you, though, is no matter what type of cancer you've had, all patients, regardless of the tumor site, stage, or even the treatments you've had, you will need to go through a process of adapting and getting used to some changes in your body image. We know that poor body image, so people that get stuck, most people recover over time, they integrate changes to their body over time. We're going to talk more about it. But we know that if they get stuck, and people that have more disturbed body image symptoms and more difficulty moving forward, they'll have poor adjustment and quality of life. And that's about 25% of the patients who have what we would consider body image disturbance. And now the good news about this area, and it wasn't the case when I started the trial, is all of the major guidelines now recommend that physicians and nurses and others start to assess more about body image adjustment during the cancer experience. Now, I just want to tell you something, just so you know, every single thing we do in treatment, everything, doesn't matter which types of treatments you had, alter a sense of body image and can negatively impact, I've got here as an example, breast sensitivity, because I did breast cancer, but really it changes body function. It often leaves scars. There may be disfigurement depending on the cancer. For women who undergo removal of ovaries, whether that's for breast cancer treatment or ovary, they'll often go into early menopause when they're young. Chemotherapy, we know, has been associated with premature menopause, but also cognitive impacts. People talk about brain fog, or fatigue is another example, which I consider fatigue to be a part of our body vitality and body image. We're going to talk about that. And hormonal treatments. If you've had men and women that have had hormonal treatments, this is just the example of menopausal symptoms. But for men too, in the male cancers like prostate, that can alter their body image and will. So here's some examples. A woman after her mastectomy tells her oncologist that she cannot look at herself or her scars. It's a constant reminder of the battle. She chooses to sleep with a prosthetic at night while with her husband. This is a young man with testicular cancer, afraid of getting sexually intimate with his new partner because he's concerned she will reject him after his procedures for treatment. And a patient with bladder cancer is contemplating his treatment options because he would not be able to conceal his ileocondyli and pouch that would be outside his body at work, worried about that and the changes that would bring about. And here's a patient with colorectal cancer as an example who underwent chemotherapy. And she said she put on a significant amount of weight and lost her hair. Her friends came over to see how she's doing, and she said that she's had daily crying spells about her body changes and frequently worries about how her hair will grow back. And many of you will know hair comes back often, but it doesn't always come back as it used to be. Now, so the cancer treatments can create considerable physical changes. This is a woman here, but same for men. There's the hair loss, there's the altered maybe function depending on the cancer in terms of a body part or an organ. Lymphedema for some patients happens, maybe peeling or itchy skin, infertility, hormonal treatment impacts, premature menopause, weight loss or gain, breast or maybe you've had a reconstruction. There can be scars and there can be cognitive changes. Now, these types of things we know, and it's been documented, will end up having a person feeling often less feminine or masculine, therefore feeling less attractive than maybe they might have felt before, and feel kind of a sense of loss of control. And this can create a situation where we see an increase in the type of specific distress, so specific anxiety or depressive-like symptoms or perceptions around body image. And of course, that can lead to depression, changes in quality of life, and of course, impact on sexual functioning and relationships. So here's some quotes. These are, the one here about feeling like a bit of a freak. I'm not a woman. That's more extreme, but these are more common. Who would want to date me now for someone who's single? I can't trust my body anymore. It failed me. I'm the mother, I'm supposed to be the caregiver, not the care receiver. So that's really a situation where the cancer experience may have shifted a role. You're going to hear about this later, but a role in how we see ourselves and our identity is also part of our body image. I'm an ugly person, I feel vain though. Now this is very interesting, and this is what I was finding in my interviews with patients. They said, I'm really glad I got through the treatment. I'm really glad I'm here. And I don't really want to bring this stuff up because the medical team might think I'm vain. And this has been one of the barriers, I think, for people getting help. This is a more extreme reaction, but a possible reaction. Someone saying, I'd rather live, 5 months with both my breasts than live a long life with just one. So these are sort of reactions. It's kind of a variance. Now, expressions of body image problems. What do we need to assess when we're a health professional? So we should be asking people about their distress over their scars or other areas of appearance or changes in their function, feeling less sexually attractive, or you can tell sometimes how people are feeling in their clothes or if they're wearing baggy clothes. Avoidance of leisure activities or intimate relations with partners. And, I often say to patients, the cancer already maybe took a lot away. If you were a swimmer before, or you like sports, there may be ways to get back to swimming again. Sometimes people get really stuck and think, well, I can't go swimming. I wouldn't possibly be in a bathing suit again, or I don't like my body. I'm not going to do that. They'll give up things they used to enjoy. And so we can work on that. And certainly intimate relations is one. Feeling less feminine or masculine, distress over specific roles, like that could be related to home. It could be a change in your work, feeling differently about your work, which might affect your identity. This is really key. Avoiding looking at yourself in the mirror, or avoiding getting dressed in daylight or kind of with a light on. Preoccupied, a lot of thoughts about physical flaws that came from the cancer experience or its treatment. And maybe extra time and a lot of effort going into appearance fixing behaviors. And then the other thing we need to assess is how realistic are people's expectations? Because I think what we did, often it's the treatments that leave people with some of the body image changes. Now, this is also important because if you're feeling negative or unattractive, or maybe less feminine or masculine, or say you feel less strong or something, these areas will affect your cognitions, are going to affect your ability to relax, or your ability to feel open, maybe, to having others see your body, yourself, or feeling vulnerable in sexual activity. So we know in the cancer populations, 20 to 75%, depending on when it's sort of assessed, cancer survivors can feel sexual problems. Some of them are more minor, but some of them are very persistent and very large, and they can last for several years. Factors that contribute to sexual functioning challenges, which is related to this area, are things like, you'll know them well: fatigue, nausea or hair loss during the active treatment, loss of libido, loss of fertility, induced menopause. So people can end up, the women would feel maybe changes in vaginal lubrication or libido, or lack of orgasmic response, loss of changes or looks to a body part or the sexual organs, if that's where the cancer was, or distress concerning scars will make people feel often quite negative about their bodies, lymphedema, and then even weight loss and gain. And even a few pounds for somebody that was really able to manage their weight before. And now maybe after chemotherapy or whatever, they can't. Find that very distressing. Some people do. So let's talk about what is body image before we go further. Like, what is it? I mean, you may be thinking it's about physical appearance, and it is, but it's more than that. So it's quite multidimensional. There are definitions in the literature. There's an embodiment experience. So it's really linked to function and a sense of ourself in a body and our mind. It involves your perceptions about yourself, your attitudes about what you believe about your body, especially about your physical appearance, but not just about that. And there are three key dimensions. So number one, evaluation. So how satisfied or dissatisfied with different aspects of appearance, and how you evaluate that. Your investment. So how important is it for you to be looking a certain way physically? What kind of energy and stock do you put into physical appearance and effort to reach a desired or even sometimes an idealized physical appearance? So investment. And then the third component is the emotional part. So what are the emotions around the body related types of assessment that you're doing on yourself, like you're assessing yourself? Now, this is a busier slide, but it shows you all the elements that help develop our body image, how we view ourselves. First, I want to really highlight one, the social cultural socialization. So how our backgrounds for women and men, or whatever gender, our backgrounds, our family, our culture, when we're in a certain culture, or in the Western culture, if I give that example, the social cultural influence on how a woman or man should look, or how a woman or man should be, those things play a role in that assessment part and how we feel about our sense of self. Our physical characteristics, so our genetic makeup, our physical appearance, what we're born with and we end up with, our personality factors, our coping style, certain situations. So people that have maybe had traumas in the past, or a history of even emotional or sexual trauma, but other types of events, sports events or backgrounds, and that internal dialogue, like we have scripts that we tell ourselves in our heads, right? Our interpretations and all our conclusions of how we see ourselves. These all go together to create these body image kind of schemas that we carry around. And this is even, of course, prior to even the cancer experience. And the thing about that is those things work together to create the emotions as well. So the emotional reactions about how you feel about your body and how you cope, and the strategies and the types of things you do in those reactions. So your behavioral kinds of reactions. The other thing that is less talked about, but I feel very strongly as part of the cancer experience and very much part of our body image, is our identity. And I'm going to spend a little bit of time on that so that you really kind of understand it. I think it's under talked about in the cancer clinics. We don't talk a lot about it. The patients will tell you, I feel a little different, or, you know, I might even feel stronger since cancer. I may feel like a different person on these areas. Or, so we know that in life in general, not just cancer, but cancer I consider a pretty extreme experience. It threatens a sense of the continuity of self. And what I mean by that is, you know, we're going through life. Think about it kind of like an escalator. You're going along in life, and then something happens. Could be a car accident, could be cancer, I don't know, could be any other type of big major event or life event. And that can change and threaten a sense of a continuity of self, something especially that's life-threatening. Bodily changes as well as cognitive changes will challenge sometimes our central beliefs and values. So, and I see this all the time with patients that have been going through cancer. So for example, people that really enjoyed their work before, they may find that after going through something so kind of life-altering and life-threatening, and even if they've done well, they may view work differently, or maybe it's not as important, or maybe certain relationships aren't as important. So there can be cognitive changes in their sense of perceived and important values. We also know that I can tell you for sure there's a mourning part of this. So if you've undergone a loss of a body part or a change in functioning, that's a loss. And there will be grief, sadness, and the need for mourning and working through that loss. That's part of the experience. How we help with the continuity of self is to help the person restore and get a sense that the escalator keeps moving and they will keep going and bring with them what they've gained and what they've lost. So to help them to continue to go forward, that's part of the intervention strategies. And people manage that sense of feeling discontinuity by, they hold on to maybe stable anchor points. So maybe a very strong belief you carry about yourself. So maybe if you were a sports person, and this can be shattered for some, and for others, they really hang on to it. I'm a physical person. I'm going to do a sport. I'm going to build strong. I'm a very strong athletic type. For somebody else, it may be a different part of their self that they may hold on to. And this is part of the key to understand how to help them rebuild, because what was actually lost, we need to know more about it for each person, because it's very individual and personal. And then when somebody's unable to achieve a sense of continuity, they can really feel, and some of you may have experienced this, alienated from others, like their family or friends. You may have negative self-views, and you may be finding you're having trouble adjusting. Even though the treatments went well, you're trying to move on, and you've got people telling you everything's to go back to normal, and maybe that's just been really hard to get back to normal. This is a very poignant artistic expression by a woman with cancer. She said, the concern for the superficial, the sensual, and the familiar skin. I live inside a skin, and I can only know it through your own derma and clothes. She called it chorus, but it does speak to loss and the shedding of a self and what's still there. I find it very telltale about the experience at certain parts of the cancer experience. Now, what is sense of self, and why do we need to think about, like, what is our self-concept? So these are all related to body image. Self-esteem has to do with your beliefs in yourself and your confidence and your self-appraisal and how you view yourself, like as a total, like the positive aspects basically, or the negative. Role performance is very specific around your beliefs or your confidence around doing the kinds of roles that you either did before that are important to you. So maybe you're a mother and you're a worker and you're a spouse and you're a daughter, whatever, those kinds of roles and what you need to do in those roles. Body image, I defined earlier, is a combination of body image, like physical and psychological kinds of aspects, but then identity, which we just talked about. Now, our self-concept though, and this is really key, and we do a lot of this in the group program that I offer. Who you are, and this is what I think we can lose sight of, who you are, and think about who that is coming into the cancer experience. So that background, that culture, how did you view yourself before? What was important to you? What was your body like before? How much did you invest in it before? All about your past self. and how much you may have internalized social cultural ideals about how a man or a woman or somebody's supposed to be or look is playing a role. They create a sense of your self schemas, your self descriptors of who you are as a person and what your body's like. Your present self obviously is where you are, and so now you're in a period in or past or moving through the cancer experience. But we also have a sense of who we hope to become, who we thought we'd become, or who we strive to become, a kind of a future self concept, our kind of future selves. And this can be everything from, what we think we're going to be like when we're aging. For some of you, it may be a sense of what you expect to be going past the cancer experience. Like this is something we all carry, whether we've had cancer or not, around how we kind of view ourselves with this sense of future. Now, what happens with people, I think, that get really stuck is when our perceived self, like the part that we're carrying around in our heads, is not close to what we want to be like, our ideal version, which may have come from your culture or the social cultural messages we get in the media and magazines and our families and our culture. When they're apart on the left, like the incongruent side, there's more distress, greater body image disturbance and difficulties. You want to move people, you want to move yourself where it becomes more fitting together. You want to move the ideal self closer to what's possible, and you want to bring your perceived self, you want to work towards something more accurate that's possible, that can still be a sense of striving towards. So let me tell you a couple of things, and these are things you can just ask yourself. If you find you're comparing your sense of self to what you should look like, or you're seeing this perceived discrepancy between an actual self and feeling inferior or less than something you think you should be or should look like, you may end up feeling a lot of what we call body shame, and we actually measured it in studies. You can assess that. Most women, I have to tell you, in our Western society, because we get so much thrown at us about weight and how we're to look and how strong we're supposed to be and fit and our body types, most women in Western culture anyway have body shame. But this can become more pronounced after something like cancer for some. And other genders are impacted as well. Men and others all have messages about their body. So individuals who particularly have internalized and adopted certain gender roles or certain ways, we're supposed to be and look, may be more vulnerable to body image adjustment difficulties going through cancer and following the cancer treatments. The other thing that I want to point out is the strength of your, I see this all the time where couples, a lot of times the person, the spouse or partner will say, I'm just really glad they're here. They're very, very supportive. But I can tell you that when the person with cancer feels broken or negative or, I don't know, not good about herself or himself, even though the strength of the partner is great, that can still be difficult. And that's why I think sometimes individual or group programs on the person is a good first step even prior to couple approaches. But couple approaches are good too. And we do know that when people have a closer partnership, they do better. But also partners need help understanding the person's feelings and what they're going through. Sometimes there's pressure on the person with cancer to get back to what they were like, or the partner may be afraid of harming them or hurting them, or really not also sure how to move forward. And in fact, some studies show that partner distress can even be higher than the person that had the cancer sometimes. So understanding and supporting from the partner is very critical to maintain healthy sexual relations and helping the person to move forward. These are some other subgroups. So these are other things to think about. Younger people may have more difficulties. That kind of makes sense, doesn't it? Because of the value on our body sense and body image. Individuals with pre-existing relationship problems prior to cancer may have more trouble. Those undergoing hormone changes may specifically have more treatment and issues around sexual changes. Pre-existing mental health history, and this is for every illness and for every area. Anybody that's had, it's just a flag, it doesn't mean for sure, but if there's been a past history of anxiety or depression or emotional or sexual abuse or counseling maybe in the past, it might mean that you could benefit from further psychosocial support going through the cancer experience. It's just a flag that it might be more difficult. And then the role of gender role socialization. So those, again, who really carry a sense of what they really are striving to be, the idealized person, how that person's supposed to look, how they're supposed to act, how they're supposed to be in the world, how others view them, that kind of thing. So when you have very kind of prescribed sense of that, they may be more vulnerable to the difficulties. Now, when I started the study, okay. When I started the study, and it's getting better, and you can tell me if it's better or not, but really, even though when I looked at the literature, there were a lot of studies, especially in breast cancer, but also in ovarian cancer, prostate cancer, and colorectal cancer, and facial head and neck cancer. The prevalence for these issues around body image were pretty high, but they were usually not treated. First of all, we're in a healthcare system that's very focused on acute care, a little bit more these days on survival and helping survivors, but we really are wanting to get people through those horrendous treatments and the best possible prognostics and outcomes, right? That's really what it's all about in many cancer centers. So, and when you're in the treatment phase, even though you're going through body image changes, it's the more acute changes. You're going through the hair loss or the nausea and the vomiting. You're going through that kind of thing. So some of these other types of things pop up even more so later when the treatments end. But during treatments, we need to keep the person, and we need the healthcare team also looking at all these treatment side effects and helping them manage all that so that they finish and are, trying to adhere through sometimes very difficult treatments. This has led, I think, a lot of patients to feeling, I can't raise this, even if I'm stuck. And how do I talk about body image? How do I talk about sexuality? And I can tell you that even today, the nurses and doctors aren't really asking too much. Sometimes they'll ask how you're doing. I'm doing a lot of workshops now. I mean, people are asking for this stuff more. They're supposed to be assessing a little bit more. But even in breast cancer, they may ask how you're doing in follow-up, but they don't often dig deeper. Like, they're not necessarily saying, well, are you looking at yourself in the mirror? Are you starting to engage in sexual relations again and that kind of thing? Because the longer you're away from that, the harder it is to get back. So what's needed? So first of all, we're going to talk about treatments. We need things that help validate your reactions and feelings of loss. They're not abnormal. If anything else you get from this, your reactions are what I would consider normalized. We need strategies that help, again, remember the continuity of self, that help you get back on track and help you adapt to loss and all the changes that have happened. We need ways to help you really look at yourself. What was there before? Who were you before cancer? What's still there? How can we bridge that continuity from the past and all those memories of yourself, and into the current experience, and help you move forward as you move to, realistic expectations and positive ones too, as you move forward towards your future sense of self. And we need ways to bring that up. Like, how do we help you? I used to run into people and I'd say, wow, they'd forgotten a complete aspect of themselves. I'll give an example in my group therapy program, but they were so focused on the current changes, they actually had lost sights of some elements of their self that was there before, like interest in some maybe activities or a sense of their creativity or their strengths or some of their interests. It's really interesting because you're really bombarded with what's going on right now and how distressing that can be. So we want ways to help you identify who your sense of self is now and then going forward. So what's needed? So this is from the literature. It's sort of busy, but I'll walk you through just kind of different types of things you could be doing or looking out if you're finding you're stuck. So first of all, some of you are making decisions about surgeries. So, there are decisional aids, like if you're thinking about breast reconstruction or other types of reconstruction, making sure that you get access to experts, or sometimes we have decisional aids that help people make decisions around, help them clarify their values and what's important to the person, because this can be very individual stuff to help you make those decisions. You shouldn't have to make them all by yourself, like just see an expert and then go home. If you need help, it can be very helpful to see an expert or use a decisional aid or an online tool to help you make the decision that's best for you. we need ways to help people cope with those changes. So everything from problem solving to maybe counseling, maybe a couple counseling, if that's what you need to help with communication around sexual functioning and how you're feeling. Mind, body, and mindfulness is really helpful to augment coping and help you get into the present moment, and help you get in touch with your current feelings and help work it through. So the other types of things are working with an expert or doing it with yourself, kind of looking at yourself in the mirror, confronting, like if you haven't looked really, it'll be painful. It might be sad. You may cry, of course, like to really start to confront gently and touching your body and these types of things. And there's some guided imagery, and sometimes working with an expert can really help. Psychoeducation is about getting information on this topic like today. And then promoting body acceptance are things like, you know, exercise and strengthening and nutrition, doing what you can to keep your physical well-being in good shape. You know, that'll make you feel good to some extent for sure. Things that help you with the buy-in you've been doing from society, like really working with cognitions that are getting in the way. Like if you're really stuck on those idealized images, starting to, you know, really challenge that and look at it. And what is it doing to your adjustment? And how is that making you feel? And what other types of role models and identities can you find to relate to? I use guided imagery a lot. I'm going to talk to you about that. And then, you know, information about the factors that affect adjustment, like for all women or for all men. Like men are supposed to be strong or look a certain way. They get a lot of messages too, just like women. Mindfulness again, and then, you know, any kind of counseling that helps around acceptance. This is another busy slide, but again, campaigns, what we need to do, and there are some people working on this, not just the cancer area, the general population. We don't want women, they're not all going to be 100 pounds. They're not all going to be thin. We're not all going to be tall. We have different bodies. And it has gotten better since the 80s. I used to work in eating disorders, but it's still a heck of a lot of pressure on how we're supposed to keep our weight and looks. And now we've got cosmetic surgery. I mean, of course that can be helpful, but you know, there's real pressure on, you know, people looking young today. So campaigns around that. Standalone self-help interventions can be helpful. Some are online. You can even do mindfulness training, by the way, online now. There are group programs that are actually online. Self-administrated things by maybe a toolkit from a professional. There are sometimes counseling, or right now virtual counseling by psycho-oncologists or social worker, psychologists that will help you kind of work through this area, or actual therapy or group therapy like some of the work I've done. Now I'm going to move to a few minutes just to talk about this trial. So I ended up getting the grant. I wrote a program grant and got a randomized trial funded. And we developed a group therapy intervention for breast cancer, though, that didn't just focus on coping. It was really body image, identity, and sexual functioning. And it was only offered to women that had already finished their breast cancer treatment. So again, after all the acute phase stuff was done, so that they could really focus on this stuff. It was 8 weeks, and we compared it to a control group. We wanted to see if we did a body image treatment, would it really work on improving body image distress, functioning psychologically, and sexual functioning. We had 3 components. I'm a big fan of groups, big fan, because I think one of the things that happens in groups is that patients have so many resources for each other, and the validation and the sharing that they do is worth so much for mutual understanding and normalization of experience. Even if I tell you individually, well, I know other patients that said that that's helpful, but it's just even better in a group. We had psychoeducational content on that whole stuff around social cultural factors. So we wanted people to have some readings. We had little sprinkles of readings for the discussions around how that was women. So how women are socialized, and how all that stuff from our past and our society might be contributing how these women were feeling as they're going through their adjustment to breast cancer. Because everybody coming into this trial was screened on a psychological assessment tool. They had to demonstrate they were having difficulties with body image. So everybody coming into this trial had challenges. And the other thing I did was guided imagery. And I did a lot of guided imagery exercises that really helped confront loss, helped people find out more about their identity, were explorations around who they are. There is an exercise around looking at yourself in a mirror, sort of to help gently the confrontation, and to facilitate the discussions. And we did the guided imagery early in the group, and then we talked about the reactions, and some of them were pretty powerful. So there was information on social cultural elements. We also had the American Psychosocial, well, the American Cancer Society had a pretty good pamphlet at the time on cancer, sex, and the female body. We gave that out so that people knew what to expect. A little bit of information on sexual positioning and communication skills, lubricants, things that could be helpful. But we just gave out a pamphlet on that, and then we talked about it in the group a bit. Talked a little bit about sexual functioning and how things play a role in that. Not as much as body image, but we did have an element of education on sexual functioning. And then we had the guided imagery. Now, these were the exercises. So, and they're so interesting. One of them, and some of them are out there, you can get them online, or you can get a script, and I'm happy to share the script with you. But the first one was really to teach individuals how to use a meditation or an imagery exercise. And everybody can learn how to do imagery. We all have an imagination, and it is linked to our physical experience, our physiological experience. Even if you just imagine biting into a lemon and you work through that in an exercise, you can see saliva starting to appear and feel that. But the inner sanctuary was really about creating a safe inner place that's calm and serene, and a place to think and to get away and to relax. So we kind of did that first. But these were the other exercises. The second one had individuals just imagine. They weren't even asked to do it. Just by imagining in a safe room with a mirror, looking at themselves in a mirror. And I could tell you that was a very interesting exercise, even just doing it in your mind. And we walked through a 10-minute exercise, and individuals were asked to imagine taking clothing off if they felt comfortable. Again, it was paced, and we did it gently, and just to see what happens with that exercise. We had a color of self exercise that really has you imagine your sense of a color or a sense of combination of colors to kind of get at sense of self. It was kind of a creative exercise. We had a future exercise around imagining a future sense, a wise woman, a sense of you ahead that would be your guide, and a wise self that would bring you forward. So we had different types of guided imagery, and you can make guided imagery as creative as you like. So our results were, from the clinical trial point of view, we had improvements in body image, and there were psychological measures for that. We had improvements specifically in body image stigma, and that got at the shame and the body sense of vulnerability, which is really getting at that sense of vulnerability and feeling not in control. We also impacted quality of life. Sexual functioning did change, but it didn't reach statistical significance. It did move in the right direction. And I just think 8 weeks wasn't long enough, and we were really just doing a lot in 8 weeks. So it moved in the right direction, but we needed more time. I'll share a little bit with the guided imagery. So that was the inner sanctuary one, where you're creating that inner place inside of quiet, peacefulness, personal, special place of your choice. And everybody's is quite unique, right? You can play an outdoor scene, an indoor scene. You can create a place, might be a place where you've been before. And then you imagine going there with all your senses, how it feels to be there, what it looks like, the sounds, the feeling in the place, and so forth. The mirror one, I talked to you about that. And this is a quote from one of the patients. She said, I felt the need, this is what she found out just doing the exercise in the group. I felt the need during the exercise to cover myself up. I didn't want to take my top off. I had an undershirt on like I have now, and then I didn't really want to go further than the bra. I left it, and I felt I wanted to cover. Then she said, I was surprised at my resistance of taking a look. Just by doing the imagery, she was able to see how much she was avoiding, like how painful, like she hadn't actually really done this. And sometimes that exercise would trigger people to go home in the next week and actually do it in front of a mirror, or to repeat the exercise. This is another woman with the mirror. She said, I can't see me at all. I saw the long hair. I couldn't look at what's there now. I wouldn't look in the mirror to see. And this woman then takes out of her purse. I even carry a picture of what I used to look like in my purse. I had long blonde hair. I have a hard time saying goodbye to that person. For her, the mirror type exercise, and it took a while for her, kind of started to confront her need to grieve and let go of a prior image. She hadn't been really doing that. She hadn't actually mourned. Her hair came back and people were telling her she was very attractive. She was a young woman, but she didn't feel attractive and her hair came back quite different. And so that imagery helped her to talk about it and start to confront and then mourn what she needed to look at. This is another example from the mirror exercise. This is a woman who said, I didn't see my whole body, wasn't able to see. She said, I only looked at my face. I wouldn't look down. I could not even view my chest area. It was just black in the mirror in the middle of my torso. I wouldn't take off my clothes. I had a hard time looking. So that's a good outcome too, because for that woman, she needed to talk about, and she used the groups to really open up about how she couldn't look. And she was just looking at her face, literally not even changing or looking at herself in a mirror. So that gently started to move her in the right direction. Another woman said, I couldn't see my whole body. I only saw my hands. So the therapist, we worked with her and we said, oh, your hands. And I said, tell us about those hands. And she said, the hands are busy. Like we really played with that. This is the way imagery works. Tell me, what is it about the hands? What came forward for you when you think and looked at the hands? And she said, hands are busy. I like to knit. I'm creative. I have strong hands and I knit a lot. And then the therapist said, that's interesting. And then it ended up leading to a whole conversation about this woman's, she used to be a weaver, her creativity. And really the conversation kept going forward. And the therapist said, well, you know, what did you notice? What did you see? What did you feel? But really she rediscovered the cancer didn't take away that very vital and important aspect of her sense of self, really highly valued. And she hadn't really considered it recently. And it was really a way to help her go forward and strengthen her self-schemas and to rebuild her sense of self. Here's another quote. I wish I'd known about the whole menopause thing. Nobody told me about it. It's been my biggest heartache. This menopause and going right into menopause, you know, when you wanted to have a child. And I wouldn't have changed things. I still would have done the surgery, but I would have been more prepared. And again, I think it speaks to sometimes we haven't done enough education to really help prepare for the bodily changes. This is another woman saying, I saw my head and my feet, all black in the middle, didn't see a torso. Another woman said, I don't feel whole. I felt better about not having a breast the first couple of months, but after the surgery, now I want it back. So again, just getting the discussions going. Here's some examples from that future guided imagery, kind of future self exercise. As you imagine your sense of future, you know, where you'd like to be, what's ahead on the path, and there's sense of a guide moving forward on the path. And it was a way that we ended off the last of the 8-week sessions. You know, someone like a wise version of yourself going forward. And here's some feedback from the group. I learned and shared a lot through the group on how cancer has impacted us. I learned I'm not alone, not to let cancer stop us from doing anything. I learned to face reality and touch my scar and look at myself in the mirror. My self-esteem went up and I became less self-conscious of my scar. The group was very helpful. You know, for some too, you know, they weren't swimmers and they had given it up for some sports, and they, you know, the group really helped them find new bathing suits and a new way to kind of get the courage to go back and to do some of those. Or sexual intimacy was another one that shifted. This woman said the group definitely assisted me in gaining new insights and understanding myself. Before the group, I wasn't allowing myself to even think about my fears and my uncertainties. Another person said, being part of the group, I know I was having the same thoughts that others were expressing out loud. By allowing myself to participate in the discussions, I became more comfortable in formulating my inner thoughts and started to communicate now more with my husband. And we did talk a lot about relationships and intimacy in the groups. So I'm near the end. Can we fix what we've broken? I would say yes. We need to help you if you need help. I think we can restore a sense of self and improve. People can improve on their body image and experience, and also re-experience and regain sexual intimacy. I don't mind sharing slides. I've listed a few cancer resources. I used to run the D'Souza Institute. I left in July, but Cancer Chat Canada, we were running, this group now was put in a version online through Cancer Chat Canada. The D'Souza Institute, we used to host it, like I used to run that. It's still operating, and sometimes we do body image groups. So you can check that website. Sunnybrook, even though it's for breast cancer, there's a little bit of information there that I help them put, even maybe some of the guided imagery exercises there. And even though if it's for breast cancer, I think it could be helpful for other cancers. And then there's some other supports there. So I guess I'll end there. I guess what I'll do is stop sharing, and maybe we have time. Thank you very much. I think I'm going to stop sharing.
Well, thank you to you. Thank you very much. It was really interesting. We have a few questions. I don't know if you can see them. Can you see the questions?
Me?
Yeah, Mary
Okay.
Jane.
I can go into the chat.
There's one from Elizabeth. I don't know where to start. I went through treatment like a champ, but I had many complications. Where do I start to rebuild myself?
I don't know where to start. I have many. What was the last part? Many.
I had so many complications. So where do I start to rebuild myself?
Well, there's a lot I think you can start to do in your own. I think starting to talk about it. I mean, it's painful to look in a mirror. I can tell you that mirror exercise every single time, even when you do that exercise, by the way, on healthy women, just walking around in the street, women get really emotional, even looking at themselves in a mirror. So of course, if you've had cancer and there's been some facial or breast changes or weight, you know, but you know, you could imagine doing that, or you can start to confront by looking in a mirror. But I think talking to people, if you need an expert, you know, all cancer programs should have psychosocial personnel. And I would encourage you to ask your medical nurse or doctors to make a referral. And if they don't have somebody in the cancer center, even seeing a social worker or a psychologist or somebody in your community could be probably even helpful. If you need an expert to help you, I think you could look at that. And some of the other resources I put in the slides. But I think talking about it, confronting it, feeling it's normal that you're going to have some challenges. It's as part of rebuilding. Exercise, some of those things you can do, like just healthier diets. Exercise, by the way, for fatigue, you probably know this. Fatigue is one of the most salient experiences of all cancer patients, and one of the longest lasting. Now, it may not feel intuitive, but one of the best treatments for fatigue is exercise, any kind, walking, strength building, anything. And it doesn't feel like it, but it's true. All the studies have shown that. It's also good for prognosis. But you know, when we move, it makes us feel better about our bodies, and it will help. Those are things you can do, your own health behaviors. But if you need more psychological help, I would ask for it and try to get some referrals.
Okay, another question that we have here is specific to couples. How do couples improve communication or get the process started?
Well, first of all, you know, we did a lot of friendly debate in the research team when we started. And I don't know that everybody would agree with me, but I feel fairly strongly about this. And I could imagine this myself as a woman. You don't have to have cancer to imagine this. When a person feels negative or broken, or like I used to see it in eating disorders, I see it in women. I sometimes treat women in general with low self-esteem, or men. I did a lot of colorectal cancer, and I worked a lot in genetics. So some of them had ostomies and so forth. So that's very challenging. If you're feeling negative, when you're having sexual relations and you're thinking, you know, those tapes in your head, I'm unattractive, I'm fat, I'm this, I'm whatever it is, it's actually going to affect all your sexual functioning, your vaginal dryness, your ability to relax, Now, there's some things you can do and cover up and gently nudge, but one of the biggest things, communication. So starting to talk, I think starting wherever you can. And by the way, even telling you, your partner and spouse may also not know how to start. Like, they may be afraid of hurting you. They may not know, they may be interested. They may not know how to restart. I do know that if you haven't been in sexual function for a while, the longer you're out of the game, the harder it is to get going. You know, the sooner you can get going with something. And look at some of the Canadian or the American cancer pamphlets, trying different levels of intimacy, just holding, starting small, holding and talking, trying new ways. Maybe you can't do some of the old things, exploring other ways to be sexual. But it starts with even expressing a little bit about your thoughts and fears if you feel safe in your couplehood. The other thing is there are people, again, experienced in this, couple counseling. Some of the cancer centers have a referral service where you can see a social worker who's experienced in couple counseling for cancer. So see if your center has that. Or it could be somebody, again, in your, depending on where you live in your community, they don't have to be cancer specialists, to help you start to talk about it. Because if you don't talk about it, it's really, you're both in your corner. It's really hard.
Thank you. We're actually coming to the end of our hour. I just wanted to say, Dr. Esplin, that I am particularly appreciated the fact that, you know, in your escalator analogy, and when you talk about normalizing, you've really just given us an opportunity to give ourselves permission to feel, you know, to say out loud that cancer does cause changes to your self-image, to your self-concept, and you know, your emphasis on the importance of rebuilding your sense of self are extremely valuable information that you've provided with us today. And for those of you who aren't familiar with the West Island Cancer Wellness Center, we offer support groups, we offer individual counseling, we have exercise programs and nutrition programs. So please visit our calendar to be able to see if there's things that we can work with you to try to help with some of these concerns. And if we don't have it, ask us for it, because we love a great challenge.
You know what, I want to tell you, by the way, I've looked at all the randomized trials. The exercise programs for men and women are actually helpful when you measure body image. The mindfulness, you can get those online. Mindfulness, you have one at your center. Mindfulness meditation, very helpful. All of those programs would actually help. And the other thing I would say, the escalator, you see, light, it is going to pull you forward. You're going forward in whatever way. And so trying to get in touch with what's still there, but and also what has come from the cancer experience. And some of that's around the survivorship piece, or the strengths you've discovered about yourself, or maybe something you didn't even know you had before, could be very helpful in that continuity. So it's lovely that you, to meet you, and that you came. I hope that you will seek support if you're feeling stuck, because it really is everybody's experience, I would say. Nobody gets off the hook in having an impact in this area. Everybody's impacted.
Well, on behalf of the West Island Cancer Wellness Center and all of the 30-some people that are here with us today, I want to thank you from the bottom of our hearts. I know your time is valuable, and the fact that you donated it to us today was amazing. Keep up the great work. We greatly appreciate it.
Thank you, and all the best to all of you. Thank you very much for coming. Bye-bye.
Thank you very much, Dr. Esplin. Thank you. Thank you, everybody.
Okay.
Have a nice day. Bye-bye. Sorry, we can answer all the questions. That's the time we had. Bye.
Okay, thank you.